Before I get started, I'm going to talk a little bit about community health needs assessments. And as a guy who practiced for a long time in the community, was actually drawn into a larger health system because I had that hardcore group of patients who had strong social determinants and really had a hard time following their treatment plan, and took a disproportionate amount of our bandwidth in the office with office phone calls, utilization, hospitalizations. And I got to thinking, wow, if we don't get after this, we're in a heap of trouble. And in an outpatient setting at that time, back in the 90s and early 2000s, not a lot of care management, social worker, integrated behavioral health types of assets to throw at these things. So it's been an area of interest for me, and certainly for health systems. One of the ways that I think we can approach that is through something called the Community Health Needs Assessment. So I'd like to talk a little about that today. Before I do that, I just wanted to say, how many here work actually for a large nonprofit or a nonprofit hospital? Okay, so a good chunk of you. How many of you have ever heard the term Community Health Needs Assessment? All right, and how many of you have actually participated in crafting a Community Health Needs Assessment or its implementation plan? Okay. How many of you are in a large group that's going to be going into MIPS? Okay, and how many people are in an APN or are going to go for that model? Okay, and then how many of you are in an ACO where you're actually in an at-risk contract where you're delivering care and at risk for that involves a care management component? Okay, so by the show of hands, virtually everybody who's in this room should have some interest in that. So what I'm hoping to do is I want to talk a little bit about social determinants and the importance and the impact of them and the role of place in health. So we talked a lot about growing health as opposed to just treating disease. I want to talk a little bit about the specifics of the Community Health Needs Assessment, and if you're pretty familiar with that, we'll go through that quickly. And then finally, I want to open up the discussion to see how we might integrate some of what's available through the Community Health Needs Assessment process, the accountability for which actually lives with the hospital, but as primary care physicians. What's our role in maybe influencing the agenda of those needs assessments? To some degree on the hospital's dime, if you will, but through that, how you might find synergies in terms of having achieved some of the care management goals, as well as some of the other efficiencies of making bigger investments, social investing within your communities, and strengthening that social safety net. Okay. So we know from the county health rankings and other sources that social determinants and health behaviors actually drive a lot of health outcomes. County health rankings estimates about a 40% contribution from the social determinants and 30% from health behaviors like smoking, drinking, substance abuse, and about a 10% contribution from the built environment. And you contrast that with maybe a 20% contribution of what actually healthcare does in driving health. So as it turns out, your zip code might be an important predictor for health outcome, rather than how many medical conditions that you have. And I think the other stat that really impressed me is relative to other developed nations, we underspend. We're laggards in terms of what we spend on social services for our patients. And if you think of the big number of elderly, one of the biggest problems facing our elderly right now is not just the burden of their chronic illness, but the social isolation because of the way the United States has evolved with a nuclear family structure and an erosion of family, and then social isolation within communities. It's a huge burden, and actually when you work to fix that or help address that, good things happen in terms of people's health. Now, as family physicians, you're very well aware that human needs influence healthcare and utilization, and so I've become sort of a disciple of Maslow's hierarchy, because let's face it, if you don't know where your next meal is coming from, you don't have stable housing, you have been abused, you're walking around in a heightened state of anxiety. It's sucking up most of your bandwidth, and so you're in survival mode, and your ability to really then attend to your own healthcare needs is really dampened. And imagine then that the feelings that you're experiencing then drives how you're thinking about it and trying to make sense of what's happening to you. That gets disrupted. It even happens with physicians. Think of how our thinking changes as we get more burned out. And so you look at the world in a completely different way, and all that's bad, right? We also know that if you have strong social determinants, that obviously adds to the workload. You're busy attending to survival, but at the same time you've got diabetes you're trying to manage, as well as maybe chronic heart disease. And your capacity to do that is diminished. There's a big mismatch. And Victor Montour described this a couple years ago, and has actually talked about workload and capacity and trying to even that out, because when they're imbalanced, health is not only restored, but you'll be able to maintain it. I think the other thing I like about this too is it actually starts to hint at our daily function as an important predictor, and we know that functional status is a strong predictor for mortality. So last time, Mike Mendoza was here from Rochester, and he's a guy who's now in public health, and he talked a little bit about this continuum of public health and then the community setting, the different populations that exist within communities, and then the interface with primary care, that first point of contact with both community and with patients, and then the rest of the medical system. So in my setting, in a Department of Community Health within a larger health network, our role has been more or less to help bridge some of that space. So a lot of what we have done is try to bring a data-driven approach by using data that we gather not just from the EMR, but actually from other community and other sources of public data. So secondary data, and then enhanced with primary data done either through stakeholder interviews or focus groups. It's the same process that's actually done in a community health needs assessment. But what the purpose of that is actually to engage members of the community, who are also our patients, and then through that process try to establish priorities, and then socialize that. A lot of what I've done at Lehigh Valley Health Network is actually educate our board, our philanthropists, our other clinicians across other departments to see that they actually have shared skin in the game, and helping them understand both the power of place as well as trying to integrate what we're doing in some cases is if we can reduce the burden of the chaos in people's lives through care management resources, as well as building up the available resources in the community. That's maybe one less patient who's going to be a real challenge to management in their space. So it's essentially framing it as a way of, here's a way to reduce your level of aggravation, or for your nursing staff or your care coordinators who have to do that. So the other thing that we have been somewhat successful in doing within a community health context is actually trying to establish innovation pilots. So in that value-based framework, I've used the term that we're a lose-less strategy. Our business folks like that because as a department we don't generate a lot of revenue, but we use the opportunity to work through grants or through collaborative efforts with primary care departments, as well as that community interface. For instance, our cardiology division both does some community presentations, but they've also now started a very small pilot for what they hope will be a randomized controlled trial for using paramedics in the community. We've used community health workers to engage young moms who've just had children and their families by doing home visitation in those spaces. And the amount of data that we're getting back as we're starting to learn really more about what their lives are like is really valuable. So we use a mix of both quantitative and qualitative methods. And then I think the biggest challenge, and one I had some informal conversations about, is how do you measure success? So what are the metrics by which you do that? And I think this is a wide open field where we actually need a lot more work. It's very different than a clinical trial because the predictors of health from a social construct or even from a biopsycho standpoint, they're different. And the endpoints. So this whole aspect of patient-reported outcomes I think is going to be very, very important as we move forward. And I think putting some discipline into that science is going to pay big dividends as you think about marrying that up as additional inputs in that sort of big data or machine learning environment. Think of the risk stratification that you could do on the front end if you just added a simple 10-question social needs screener to someone at the time of enrollment into a plan, and you have a much better sense of what the lift is going to be in terms of keeping that person out of the hospital and keeping them healthy. So the question I'm going to have for you is, how can, in this milieu, you achieve your population health goals And then also from the business proposition, how can you integrate the clinical care with trying to, if you will, keep the weeds down from folks who have strong social determinants. And how do you do that synergistically with the goals of your hospital that has had more of a service line orientation and is really trying to, if you will, continue to build their footprint or in the geography, understanding that as they expand, they take on other communities who may have very different characteristics. And so you see one community, you see one community. And so I think you'll need a menu of strategies. What works in a medium-sized city like Allentown will not necessarily work the same in one of our rural campuses, up in the Pocono region in northern and eastern Pennsylvania. So let's talk a little bit on Chinna. Anybody want to try to define a community health needs assessment? Or just review quickly, maybe? Basically, it's a self-study. It's a 3-year cycle for looking at a number of domains that influence folks' health. And it's meant to be a collaborative thing, so it's designed to engage the community as well as the stakeholders of a particular health system. It's actually mandated through the Affordable Care Act as a way for nonprofit hospitals to justify their nonprofit status by virtue of what they're showing they are doing in terms of their community benefit. The components really are, it's a data pool using secondary data enriched by primary data gathering. And then that comes back to some type of a steering body, and this is where I think you can have greater influence in terms of what's important. From that then is a requirement to set up, if you will, an implementation plan with a very small selected list of priorities, and then over the rest of that 3-year cycle to measure the impact of whatever tactics are chosen in terms of where that work's getting done and measuring that. All right, now that can be a process or an outcome or even an output type of a measurement. And then the subsequent cycle you build on the previous work and continue to refine those priorities. So each licensed campus needs to have that. That's a little bit of a nightmare for those large systems that have like 20 campuses. And again, many folks have local experts. Who are those local experts? Folks like you. As well as your care managers, as well as some of the leaders of your community and faith-based organizations. So I think the other thing about the community needs assessment is its emphasis is on vulnerable populations. As a nonprofit, they have an obligation not to just chase the dollar, but to really focus on those that don't have. So you are actually focusing and can become part of a Medicaid strategy. Those of you know Jeff Brenner from the Camden Coalition, recently was lured away by United Healthcare. I had a chance to talk to the president of United Healthcare Community and State back in October. I was at a presentation done by Optum Labs. United is part owner of Optum Labs. And he said, well, our strategy is pretty simple. We hired Jeff because Jeff can go into a community and with his knowledge and background of building coalitions, he basically can get out there and using the stakeholders in the community and his facilitation skills can actually build up and strengthen the social safety net in those communities so that they are willing to offer more or less at lower cost the ability to help stabilize people's lives so they can participate better in their health care. And then we go in and we're content to take a little lower profit margin in those markets. Instead of 6%, our expectation is only 3%, but because he's done the field work, he's strengthened the social safety net, he saves us tons of money. I thought that was pretty brilliant in terms of a particular strategy. So these are the domains, and concentrate more at the top of the slide here. The domains on the front end, where we are gathering the data, have to do with health outcome metrics like mortality and morbidity, pretty core to what most health systems are looking at. Healthcare quality and access, pretty core to what health systems are looking at. And then health behaviors, and then demographics and social environment. And as you look down that column there, you'll see there are things there that really truly are sort of multi-sector, poverty levels, educational attainment, employment status. Homelessness, a big one. Housing is health. and we're starting to see some real movement in that area, although that's typically done through a coalition approach. And then the physical environment, so safe places for kids to run and play. We have an obesity epidemic like everyone else, but when we did the primary data gathering, we learned from parents and kids. I don't want to send my kids out there because of gang violence. I don't want them to get caught in crossfire. I don't want them to go to the park because that's where the drug dealers are hanging out. And there's vials and other paraphernalia on the ground. But you could engage our local law enforcement folks, have some interest in working, as do our faith-based organizations, of creating safe places for kids to be able to go after school where they can play and they can exercise. And while it's small work, it's kind of recreating, I'm hoping it's kind of recreating maybe some of the communities that many of us grew up in, and can try to combat one of the root causes of something obesity. Something like that actually would count as noble work, within a community needs assessment. But look here in terms of, as you think about whether you're in charge of quality, whether you're in charge of strategy, if you look at some of these domains, and then if you were to take some of the metrics that you might choose, cancer rates, hospital utilization, provider rates, chronic disease, asthma-related hospitalizations, how many of them are core to the work that you're already doing? And so you have this wonderful opportunity to get a hold of whoever's in charge, or if you are helping to direct some of the activities of the needs assessment, you have a bully pulpit to say, this makes sense from the triple aim and the quadruple aim perspective. By using some system implementation things to the needs assessment, you're going to get some resource commitment from your health systems. You may potentially then unburden, or you may have extra resources that help support your other primary care physicians, practices, and care managers who are doing this work. So at our network, we boil down, if you will. On the front end, you do the data gathering. On the back end, then you need to use some type of a participation approach. This last time around, that group was not as broad as I would like it to be. I do think there's really good work happening. I like a lot of what WellSpan in York County in Pennsylvania has been doing. They cover multiple counties, and they actually have a by-county coalition of business leaders, other community-based organizations and faith-based organizations, and actually some of folks who are those who use those services. And they've brought them together, a group of 40 or 50 people, and they take a look at the raw data from the needs assessment and actually help with the prioritization process. And then the hospitals within their network actually bring that home, and they use a multidisciplinary group to sit down and invite their board of associates, board member, participants from the community or the practices. A few of our practices have patient advisory groups. And in a perfect world, you could bring those folks together to further refine. So we boiled this down to 4 priority areas. They're purposely inclusive because this first time around, the goal for our network was, let's really broaden awareness. A lot of our clinicians really didn't have any idea what a community needs assessment was or why it was important, and we wanted to change that. I think moving forward, the goal would be try to bring a little greater specificity and maybe do a little deeper dive in terms of working on fewer tactics, but doing a better job with them. So these, in terms of prevention and wellness, we chose to focus primarily on obesity and cancer screening. And then we have done a lot of work. Wanda, your presentation was very helpful in validating, I think, a lot of the good work that we're also trying to do in educating our clinicians, developing tools for assessing patients, and then also providing more rapid access. We have warm handoffs now going on in an emergency department. We started in the at-risk populations. We have a lot of veterans in our community. A lot of them are suffering from PTSD. We have a lot of depression in our community, and so everything that's mental health, we've tried to do a little better job of, can we identify it, and then if we can identify it, can we actually help to care coordinate it? So for instance, in our network, if you have an abnormal mammogram, you have a care manager who calls you, and they actually navigate you right to meeting with the surgeon, getting the biopsy, working with an interventional radiologist, whatever it takes, right? If you screen for moderate to severe depression, we write a referral for you to go and get seen. We found that out of 700 referrals for that purpose, about 150 of them were hitting a dead end in the referral system and died there. And it's like, wow, that's no way to really help people who are suffering. So we actually negotiated and just recently got, with funding from our PHO, a care navigator specifically who would help a person who's been identified with depression to work with them within their health insurance plan and the other resources that we have, and get them plugged in with a warm handoff and get it done quickly, even though they may not be able to see a psychiatrist for 2 or 3 months, particularly with the Medicaid rules in our state. So these are little wins, but they're little system improvements that we've been able to do and say, you know, I'm not going to change depression overnight, but we have used that as a quality-driven, you know, modeled after some other programs, to take something that for a lot of clinicians in our network, when it comes to mental health, they're just sort of like, yeah, let them take care of it. And it has brought it into the space where you're trying to mainstream it a little bit better, right? So in the third area, community engagement, a lot of this has been around opioids. There's been some significant work done around homelessness. We have a street medicine program that has been very successful. It's generated a lot of goodwill and some really great philanthropy. Tried to use that as a springboard to get to the policy issue of housing. So we had one of the highest rent-to-income ratios in the United States for the city of Allentown as the center of our town gets gentrified. And the influx of young, upwardly mobile people who have good jobs in the center of town has been great for the center of the town. But there's still a collar around there that has been problematic in terms of helping the people who've always lived there, and what can they do to improve their streets, their homes. How do we take, you know, we did through veterans have a win with rapid housing, getting folks housed, and leveraging some of the resources within the VA system as a model of doing that. But even the opportunity to frame this as a human crisis as opposed to a policy problem has been helpful as you get before our Board of Associates and some of the educational presentations we'll be able to do. Progress remains slow, because it's sort of like, I had a board member recently say, is this what we really ought to be into? I mean, we're a tertiary hospital. We deliver high-quality healthcare services. You know, housing, you know, that's not our business, all right? And so trying to get them to understand, our CEO stepped up at that very meeting and said, guess what? These are all the people, it all rolls downhill. These are the people who stand up in our ER, who then clog up our hospital and reduce throughput because we don't have any place for them to go. I was sort of very grateful for that level of witness, if you will, to the work at hand. So, and then access health equity. I think most of our attention has been paid on the rapidly evolving racial and ethnic mix that we have in our community, and the growth of interpreter services. So I love the iPads and the video connection for live interpreter as opposed to the old blue phones. And we've tried to implement that as we've integrated 3 additional campuses into our network in the last 2.5 years. We've had a rollout for that to go with our IT efforts. And I'm pleased that, you know, that's actually happening, to where the feedback from both administrators and a handful of clinicians is, hey, I really like this. It really makes the encounter easier. It reduces my burden of slowing me down in my day. Okay, that's a win. That's a protector against burnout. So there's little ways that we can help in the culture that we're trying to support, but at the same time, you know, get a check mark of here. So taking this from a check mark exercise, we just got to get it done, to making it more meaningful is really what we're hoping to do. This is just a brief overview. We have, at this point, 5 campuses. 2 are actually jointly licensed. But in terms of some of the things that we did, if you look at these closely, a lot of these things are things that you're already doing or would not be hard to do, in terms of a little bit of outreach. Many of your patients who see you are leaders of nonprofits or faith-based organizations. It's easy to engage them or invite them to come for some type of a meeting to talk a little bit about where you could apply the energy. All of our outreach now done through, or the folks who come looking for sponsorships, who come to our marketing department, they now use our needs assessment as sort of their standard for whether or not they're going to make a donation or lead to a sponsorship. If they're part of the needs assessment, the answer is yes. And a lot of them who've been coming for years and say, well, we always get $5,000 for you, the answer is, well, does anything that you're doing fit with our needs assessment? If the answer is no, well, sorry, we've had to change the way that we're doing it. So another area where there's been some influence. The more rural campuses have larger access issues. particularly for specialty services, so bringing high-quality care closer to home has been one of the points of emphasis for our physician group as we look at health centers and where to expand them on the outpatient side. And then I think in portions of the Slate Belt in Pennsylvania, there's high rates of cancer. So a lot of these, come from coal mining families. There's a lot of smoking that goes on there. And so something like lung cancer screening is very fledgling in that area, and there's an opportunity now to try to bring that to scale. In fact, Grant has some ideas that he's been working on implementing to help with some of that. So in summary, I think there's a lot here, and I think as clinicians in family medicine, many of you are leaders within your health systems. There are opportunities here, if you will, to hit multiple targets. Help targets at the micro level within your clinical microsystem, sort of that meso level is sort of that layer where internal institutional policy and direction is being set, and at the macro level is that if we can get after the social determinants a little better and build that social safety net, I think there's an opportunity not to just reduce costs, but I think we're going to see more patient engagement, more motivated patients. I think it's going to help increase our joy of trying to help these folks, at least knowing there's more energy. I'll finish by just one example of that. Everybody has a community resource directory. Usually it's on paper or maybe it's built into Epic. We partner with our United Way. They have this elegant system called United Way 211. And it's an online resource that also has a local 1-800 number that they can call for whatever they happen to need. What's nice is they track every call, and so we get data from them about the types of calls and the types of needs that they're addressing. We committed small portions of a couple of our staff to help them update their database. They fanned out and talked with our case managers, many of whom have their little crib sheets, right? And we said, no, let's put it all into here so you have one place, one-stop shopping for our internal folks, for our community folks, and for our patients, because they have a patient-facing. It was a huge win, because our clinicians, I've been pushing, although I don't know that it's happened yet, is to get that as a link, an embedded link within Epic, so that a clinician in the workflow, if he's able to do it or she is able to do it, great. If not, have whatever person's helping with some of the care management aspects, but it just flows as part of the workflow. And now, there is now a place and a space where people can call. And then we've been working with the top 10 community-based organizations working on what are the top 10 needs. And then as a feedback loop, that helps from a policy standpoint. It's a data feedback portion so that when we do our next cycle of the needs assessment, we're going to be looking and doing a deeper dive. So for instance, we're starting to do some data sharing, particularly around mental health and depression. When we say mental health, it's hard. They look at the number of providers. We actually got an agreement to establish a standardized query that will be used by all the health systems and all of the mental health outlets to interrogate either their problem list or whatever data where they actually keep their diagnosis list, so that we have a better sense of when we say mental health, what are the most prevalent mental health conditions in Lehigh Valley. And that'll be much better than what we're currently getting, which is basically says you have a mental health problem in your community. We know that depression, anxiety, eminently treatable. And I think if we can understand what those targets are, it's almost like saying you have cardiovascular disease. Well, is that hypertension? Is it heart failure? Is it chronic kidney disease? It makes a big difference. So thanks. Appreciate your attention, and I'd love if you can help me with any of these questions above. I'd be grateful.
Thanks, Bob. That's good.